Thank you. Thank you all for coming. I'm Veronica. I work with 10 doctors in radiation oncology, thoracic service, and we deal with thoracic cancers of the chest, and mesothelioma is one of the ones that breaks our hearts. So today I'd like to talk about mesothelioma with you. I know that the previous speakers, Vicki has gone over chemotherapy options and Dr. Rice did surgery, but I wanted just to go a little bit over just general review of everything. Mesothelioma basics. The definition of mesothelioma is abnormal growth of the mesothelial cells in the lining of the lung, which is called the pleura. There are 3 types of mesothelioma: epithelioid, which is the most common, sarcomatoid, and biphasic, which is mixed of the both. And the sarcomatoid and biphasic have worse prognostic factors. Causes of mesothelioma is attributed to exposure to dust or particles of asbestos. A lot of painters, a lot of people in military have been associated with higher incidences of mesothelioma. However, some patients may be family members who never worked in the asbestos industry, but we see wives or mothers who may have washed the clothing of people that worked in those areas. So there are common treatments for mesothelioma are surgery, chemotherapy, or radiation. As previously discussed by Dr. Rice and Vicki, for when we see a patient with mesothelioma, first thing is to make sure that you get a complete picture of the state of the disease, and we use a lot of different modalities. Chest x-rays are usually how they're first indicated. People present to their doctors with progressing shortness of breath or fluid in their lung, and ultimately they have CAT scans of the chest or abdomen done, or most recently PET CT scans that can show us the whole body. If a person comes to MD Anderson's, typically our staging workup is to get this imaging done, and we also do a surgical staging, which Dr. Rice talked about, which may include a mediastinoscopy to look at the lymph nodes in the middle of the chest, and even laparotomy to check the diaphragm and the abdomen to make sure that none of the disease has gotten below the diaphragm. So once patients are staged, and there's common known staging system by the American Joint Cancer Consortium. This is the 6th edition, and they're fixing to update this. It'll be adopted in January of 2010. But for general purposes, everybody in cancer field uses a T, N, and M staging. T stands for the size of the tumor, N is the lymph nodes, and M is metastasis. In general terms, the T will tell us where the tumor is located, and in mesothelioma, it's important to us to know, is the tumor affecting the inner lining of the lung, the outer lining of the lung? Is it abutting some fissures in the lung? Is it near the heart, the diaphragm? Is it near muscle, fat, ribs, abdomen? Is it on the opposite side of the lung or in the pleura? So it's very important for the surgeons and for the group to know where the disease is at. If lymph nodes are involved, we need to know, are they on the same side as where the cancer originates? Are they within the lung? At the hilum, which is where the bronchioles come out of the main bronchus? Are they near the mediastinum, closer to the middle of the chest, or on the opposite side? Metastasis usually means that the cancer has spread to the opposite side of the lung and may be unresectable. So treatments, again, previously discussed chemotherapy. We used to use a lot of cisplatin, and recently we used asatinib or Alimta. Surgery options, as previously discussed in the past years, if the cancer was felt to be resectable or not involve mediastinal lymph nodes or not involve distant metastasis in the abdomen or below the diaphragm or on the opposite side of the lung, then patients were offered an extrapleural pneumonectomy. These days, if the patients may have more extensive disease in multiple areas, they might not do an extrapleural pneumonectomy or consider a pleurectomy and decortication that Dr. Rice talked about in his last talk. And somewhere along there between chemotherapy or after surgery, radiation is used to try to eradicate any microscopic disease that might be left behind, or in patients that are not surgical candidates, to give them palliative radiation to try to delay or eradicate the disease or delay the growth of the disease. So radiation has been around a long time. Radiation is like having a chest x-ray. And when I started here in radiation, when I came to MD Anderson, initially there was just two types of radiation, two-dimensional radiation. That means that just wherever your cancer was at, the radiation was aimed at you and it went through your body that way. Three-dimensional radiation, we all got a little smarter, and we, instead of just drawing on an x-ray, and I'll show you, this was it. This is your chest. These are your collarbones, right lung, left lung. This black area coming down up an inverted Y is your bronchus, your trachea that goes down to your bronchus. And if mesothelioma was involved, we would just aim a beam of radiation at that and not really be able to consider what else is there, which is your heart, the lungs that are not affected by the cancer, your esophagus, which courses through this area, or your spinal cord, which also courses through this area. So years ago, and not so long ago, probably 1990s, 1995, that's how radiation was given. With growing technology, though, we were able to, and this is just a picture of how radiation was aimed. So this was somebody's chest. They took a chest x-ray of you. The X mark was where the tumor was located centrally. They drew a block around it, and this was the area they treated. And these hatch marks were the areas they ignored or tried to ignore to spare, and radiation was given to this area. But as you can imagine, your bronchus, your esophagus, your spinal cord, lymph nodes got radiation too, even though we may not be trying to aim at those areas. So with improved technology, with CAT scans that were used for workup, this is another way to look more closely at details in the lung. And this is a CAT scan. This is the right side of a lung, left side of the lung, muscles and back. And so depending on where a tumor was, then the doctors could outline or contour where the tumor is at, and then try to aim radiation at just those areas in order to spare the lung tissue, to spare opposite lung. So once a contour is done, we do a simulation planning session, and I'll talk more about that and the techniques and devices that we use. But we bring people to radiation if it's decided that it's time for them to have radiation, or if they can't have surgery. We do a CAT scan that is like a typical diagnostic CAT scan, and then the doctors will slice by slice go through the scan and outline where tumor is at. So like on this patient, these are all slices of the lung starting at the top. These are the heads of the collarbone, right lung, left lung, the spinal vertebra, your shoulder blades here, and they go slice by slice, and then the red is where the tumor, or the area of interest, where we're aiming at. But because things move in your lung when you breathe, and when you breathe in or out or up and down, we put some margin around it. So that's what this yellowish and green colors around it. So slice by slice, the doctors will contour the areas of interest. And then our physicists, our dosimetry group that at MD Anderson are specialized just for thoracic. So our group deal only in thoracic cancers, will make a beam arrangement of how to hit these areas of interest, but avoid the other areas, avoid the other lung, or minimize the amount of radiation that goes to those areas.